Okay, I think we can go ahead and get started. It's my pleasure to introduce this afternoon's grand round speaker, Dr. Douglas Nordze. Dr. Nordze is an associate professor of psychiatry in the Department of Psychiatry at the Dartmouth Medical School. At Dartmouth, he serves as the Director of Psychosis Services and is the investigator and member of the Psychopharmacology Research Group at the medical school. Following his graduation from Washington University School of Medicine and also his residency at the Dartmouth Hitchcock Medical Center, he joined the Dartmouth faculty. During his career, he has held a number of hospital staff positions, has served as medical director for a number of clinical entities, and has been a member of scientific advisory boards and committees. He serves as a referee for a number of psychiatric journals. His major research interests include clinical and medical trials for individuals with psychotic disorders, exploration of methodologies aimed at optimizing treatment outcomes of individuals with schizophrenia, examining interactions between psychopharmacologic and rehabilitative or recovery interventions for individuals with severe mental illness, and also correlating criteria for early schizophrenia spectrum disorders with rates of sustained remission to support decision aids for treatment. He is the recipient of numerous research awards. His work has been published in a number of scientific journals, and he has lectured widely at regional and national forums on the clinical challenge of treating schizophrenia and severe mental illness. This afternoon, Dr. Nordze will be discussing antipsychotic treatment at salient junctures for patients with schizophrenia. Dr. Nordze.
Thank you very much. It's great to be with you all today. I wanted to present some of the recent work that we've been doing in a couple of our studies, and so they sort of look at two different ends of treatment approaches for people with schizophrenia, and hence the title of sort of bringing together two studies that address treatment at the first episode as well as folks with more chronic illness. And these are my disclosures in terms of relationships with industry as well as research grant funding. Can you hear me okay? Is the mic close enough? So just by way of introduction, we certainly consider antipsychotics to be a mainstay of our treatment for folks with schizophrenia, but response rates are while most patients will get some level of response to antipsychotics, response rates in terms of making substantial difference in symptoms are actually rather low. So what you see here is that about 60 to 70% of patients with schizophrenia will demonstrate a response if you define it as a 20% improvement in symptoms. But if you look for a 30% improvement, that drops to half or less, and remission defined by either more substantial symptom improvement to very low levels or functional outcomes maybe as low as 10 to 20%. So the majority of patients treated with antipsychotic medications are getting some response, but limited response. And our efficacy in non-psychotic symptom clusters is significantly less than in psychotic symptom clusters. So that leads to sort of a couple of strategies for thinking about how we may improve responses for people with schizophrenia. One is the notion of primary and secondary prevention, primary referring to before a patient is diagnosable with schizophrenia, secondary meaning once we make the diagnosis of schizophrenia, being able to treat early and to prevent relapse in order to prevent progression into more severe symptoms. And the first portion of the talk will look at the literature on that as well as some work that we've been doing in that area. And then the second strategy is to combine antipsychotic treatment with various forms of rehabilitation and psychotherapy. And I've listed a couple here that our group has been working on. Supported employment, we've done a number of studies on through the 90s and 2000s, cognitive behavioral therapy and integrated dual disorder treatment for folks with substance use disorders. And I'll talk about a study that we did collaboratively with the group at UCLA, looking at an integration of supported employment with antipsychotic medications to enhance responses. So starting with the first episode on the early presentations of schizophrenia, we know that most patients actually who go on to develop schizophrenia will have some degree of prodrome that's fairly nonspecific, with social and functional decline. Cognitive symptoms may emerge as much as 3 to 5 years prior to diagnosable schizophrenia. Some studies show depression commonly in folks who are going to go on to develop schizophrenia, and anxiety, as well as some nonspecific suspiciousness, unusual thinking. Substance use is quite common. But this sort of functional, now having teenagers myself in my life, I know that many of those sort of shifts in behavior and functioning aren't that uncommon for normal adolescent behavior, as well as a range of other psychiatric disorders may present with nonspecific symptoms. Patients often don't look stereotypical, and as we've done our first episode work, our hospital staff often will come to me on the side and say, well, you can't be making a diagnosis of schizophrenia with this person. They don't look like it yet, and of course, that's the point. We want to try and treat people before they look, stereotypically mentally ill in order to prevent that progression. But the primary strategy in psychiatric care has been actually to give softer diagnosis initially, call it bipolar, call it substance-induced, and wait to make a diagnosis of schizophrenia until we're really, sure the person has had several relapses and it's clear that that's the disorder. Unfortunately, that's a lot like not calling it cancer, not telling the person they have, a significant disorder until it's so obvious, that treatment may be less effective. And in fact, it turns out that in the United States, most first episode studies find that the average patient is coming in with 2 years of untreated psychosis prior to study entry. And there's substantial evidence that the duration of untreated psychosis is correlated with poor outcomes. First episode patients are more treatment responsive, and longer durations of untreated psychosis are associated with poor outcomes. It turns out that for every year of untreated psychosis, you have a 15% lower chance of getting into remission from your illness. And it turns out that the association with duration of untreated psychosis is independent of premorbid functional status and whether the person has an acute or an insidious onset, and relapses have been shown to lead to poor responses over time. This is probably one of the best studies looking at duration of untreated psychosis. Tom McGlashan at Yale collaborated with a group in Scandinavia where there was between Denmark and Norway, a regional first episode treatment program with kind of ideal services, but they still were finding that it was taking several months to get people into treatment. So they developed an early intervention, an early identification and outreach intervention in 2 of the 4 regions in order to prospectively reduce the duration of untreated psychosis to really establish the relationship with long-term outcomes. And it turns out that with the intervention, their 2 early detection regions got the duration of untreated psychosis down to 5 weeks, or a little over a month, relative to the 16 weeks seen in the 2 control conditions. And with earlier, and then the treatment that folks got was the same. It was the same naturalistic combination of antipsychotic treatment with family intervention and case management and psychosocial support. And it turns out that by identifying people simply, 11 weeks earlier, psychotic symptoms, negative symptoms, and suicidal behavior were all less significant, less severe at baseline, and persisted over a 2-year period of time, with particularly negative symptoms, cognitive impairments, and depressive symptoms being less severe in the group that started treatment earlier. And the authors pointed out that those are the symptom clusters, of course, that we have the hardest time treating with antipsychotic medications. So being able to treat earlier helped to prevent progression of those symptoms. So if we think that the field has really moved to the point of viewing a critical period with neurodegenerative changes occurring in the brain, and a sort of a fulminating process of progression from a more treatment responsive state to a more fixed treatment resistant state over time, over perhaps a couple of years. Looks like somewhere around the third relapse is when a patient starts to have more of the characteristics of a person with chronic schizophrenia. Again, thinking about the parallels to oncology, if you've had your third relapse with a cancer, you're in pretty bad shape, and you go on to have tertiary disease. Probably most of the schizophrenia that we're treating, and we're used to seeing the sort of stereotypic patient, has a sort of a tertiary form of schizophrenia. And actually, Tom Insel, who's the director of the National Institutes of Mental Health, wrote a very nice editorial in Nature this past year, really using that model and talking about the need to start staging schizophrenia using staging terminology to help us to think about how we might move forward with clinical research in this area. Medication discontinuation is really common. Substance abuse worsens outcomes, and so the movement towards trying to demonstrate that early recognition intervention can improve outcomes. So there's a number of studies with antipsychotics in first episode, and I'm going to just review the literature on first generation versus second generation antipsychotics. It turns out their overall efficacy is similar, although first episode patients experience the expected side effects at higher than usual rates, with more neurologic side effects with first generation agents and more metabolic side effects with second generation agents. And the advantages that we do see for second generation agents are primarily in the areas of rates of discontinuation or remission and relapse rates, so that second generation agents tend to have higher rates of remission and lower rates of relapse in some studies. And we'll just go through that quickly. Robin Emsley in South Africa did an early study with risperidone and haloperidol, fairly high doses, 4 to 16 milligrams a day of each. This is back in the 1990s. Showed similar response rates in a group of people with schizophreniform disorder or schizophrenia. Todd Sanger published this sub-analysis from the olanzapine registration trial of people who were defined as being in early stages of illness, although they'd had a fair amount of prior antipsychotic treatment and allowed people who had been ill for up to 2 years. They showed a significant advantage for olanzapine, but the haloperidol group had almost 2/3 of patients dropping out. And again, doses were fairly high, between 5 and 20 milligrams a day. Jeff Lieberman and my chairman Alan Green and several investigators collaborated in a Lilly-sponsored study of first episode patients looking at olanzapine and haloperidol. You can see they randomized about 130 people in each group. The primary 12-week outcome, and again, this is a randomized double-blind study, showed that response rates defined as 30% improvement on the PANSS were similar between the two agents, with average doses of about 9 milligrams of olanzapine a day and about 4 of haloperidol a day. Still, relative to some other studies, closer to, maybe a little bit lower. Many chronic studies show olanzapine doses around 15 milligrams a day, so somewhat lower, at least on the olanzapine side. But greater weight gain with olanzapine, greater EPS with haloperidol, and a greater discontinuation rate again with haloperidol, dosing around 4 milligrams a day. Another component to the study was that was really quite nice was serial MRIs, and they were able to demonstrate. There were actually 3 groups here: a group of healthy volunteers, and so you had MRIs at baseline 12 weeks and then at 1-year follow-up. And if you just look at the baseline, that both groups with schizophrenia had smaller overall gray matter volumes than the healthy controls at first episode. And the folks that got olanzapine treatment maintained their brain volumes over the course of a year, whereas the folks randomized to haloperidol showed progressive tissue loss. So one of the more compelling studies suggesting that there may be a propensity for some agents, and olanzapine is one of the agents that's been shown to have at least part of its action at glutamatergic and NMDA sites, which are involved with cell death, and that there may be some capacity for some of our antipsychotics to help with preventing neuroprogression. My boss, Alan Green, then went on to do a sub-analysis of folks with substance use disorders and found that there was a high rate of substance use disorder, 37%, with 28% having cannabis use disorder, 21% having alcohol use disorders. Folks with cannabis use disorders had earlier onsets, and folks with substance use disorders had more severe positive symptoms but less severe negative symptoms. Another number of other studies have replicated that as well. And the folks with substance use disorders had a longer duration of untreated psychosis, and as you see here, significantly lower response rates to olanzapine or haloperidol. And then Alan also did a longer-term follow-up and found that by the 2-year point, response defined a little bit differently here. You saw, again, similar response rates. Doses had crept up slightly, but olanzapine was associated with a higher remission rate, longer time to discontinuation, but again, more weight gain with olanzapine and more EPS with haloperidol. And meta-analyses show that the magnitude of weight gain and neurologic side effects is substantially greater in first episode patients than you see in chronically ill folks. Nina Schooler did, out of downstate in New York, did a study with more modest doses of risperidone and haloperidol. Again, showed similar response rates with a definition of 20% improvement, but the time to relapse was almost twice as long, more than twice as long actually in the risperidone-treated group at 466 days versus 205 for the haloperidol-treated group. So again, you don't see much difference in immediate symptom response, but where you see an advantage for second-generation agents is keeping people in remission longer, and of course that's part of what we're aiming for. Again, more weight gain with risperidone, at least in the short term. Crespo Ficaro in Spain looked at randomization between olanzapine, risperidone, and haloperidol. An open-label randomized design showed similar response rates and similar times to relapse, and as you might expect, more weight gain with olanzapine and risperidone than haloperidol. Delbert Robinson at Hillside in New York did a randomized NIMH-sponsored trial between olanzapine and risperidone and found similar response rates with a trend toward better response with risperidone as well as better metabolic outcomes with risperidone. So they're now replicating this trial with risperidone compared to aripiprazole to see if you can get a more reasonable metabolic profile. Joe McAvoy at Duke, together with Diana Perkins, did this large randomized trial of olanzapine, quetiapine, and risperidone. In this study, olanzapine and risperidone did better than quetiapine for positive symptoms at 12 weeks, and olanzapine was still better at 52 weeks. Similar rates of EPS and more weight gain with olanzapine in that trial, and I'll show you the discontinuation in a moment. Renee Kahn, this is the UFES study from Europe, where they in this case you're looking not at response rates but at all-cause discontinuation, randomization between haloperidol and 4 second-generation antipsychotics, including amisulpride, which we don't have in the U.S., and ZPS is ziprasidone. And haloperidol had a higher discontinuation rate than all 4 of the second-generation antipsychotics, although again symptom change was similar, about 60% across groups, and weight gains ran as you might expect. Lynn Sikic, who was a classmate of mine from WashU, who's now at Duke, did this study in very young individuals with schizophrenia and schizoaffective disorder, randomized double-blind 8-week trial with response defined by change both on the PANSS and the CGI. Didn't find a significant difference in response rates between olanzapine, risperidone, and molindone, and found less weight gain with molindone but more akathisia with molindone. And then Diana Perkins, who was part of the Duke study, addressed non-adherence. It turned out that their experience was, as most of us have experienced, that almost all of these patients end up going off of antipsychotics at some point, that the consequences of relapse, of course, are substantial. In their trial, they found that lower efficacy of the antipsychotic, having a substance use disorder or having depression were predictors of greater likelihood of non-adherence. And as well as lack of insight and acceptance of the disorder. And she is one voice who has proposed actually the consideration of long-acting injectables. There are actually now a couple of trials sponsored by Janssen looking at risperidone long-acting injectables. It's the only one that's been looked at in first episode patients. And this is the best one, quite a remarkable trial. Robin Emsley, again in South Africa. This is a non-randomized, open-label, single assignment to risperidone long-acting injectable, but 50 individuals under the age of 43, newly diagnosed with schizophreniform schizophrenia, treated with risperidone long-acting injectable for between 25 and 50 milligrams a day for a 2-year period of time. 2/3 of the sample got into remission based on the now accepted working group criteria of both symptom improvement and functional improvement. And the average time to remission was 6 weeks. And so of those individuals that got into remission, 97% of them sustained their remission to the end of the 2-year treatment period with assured medication. So again, relative to the the relapse rates that we see otherwise, essentially, the finding here, and again, it needs to be replicated under experimental conditions, but the finding here is that if you can keep people on medications, those folks who get to remission can largely be kept in remission, and of course, sustained remission, that gets close to a cure, and that's obviously what we should be trying to achieve. Remission was associated with requiring lower doses, less EPS, and a better attitude towards medications. So, what about clozapine? We actually are looking at clozapine in first episode patients, and there's some literature suggesting, gee, why not use our most effective agent first rather than saving it for last when people might have less opportunity to respond to it. A couple of authors have taught in this group at Harvard, led by Wang, did a decision analysis and found that first-line clozapine might lead to small gains in quality of life and moderate cost. Hofer in Austria described a naturalistically treated group of patients that had higher response rates in first episode patients versus chronic patients when treated with clozapine, with a fairly similar side effect profile. Margaret Werner at Hillside did a trial with 34 patients with clozapine, compared them to historical control of patients treated with fluphenazine. Found that about 2/3 of patients responded to clozapine, but they had a longer time to response and a fairly high dropout rate compared to their fluphenazine comparator. The best study so far was done by Jeff Lieberman, collaborating with a group in China, and it turns out in China the Han Chinese population has extremely low risk for agranulocytosis based on their HLA types, and so you can use clozapine without blood monitoring. There's no requirement for blood monitoring in China, and it's used freely as a first-line agent in that country. And so they randomized 160 patients over a year's period of time to clozapine with a control of chlorpromazine, a first-generation agent with a fairly otherwise similar side effect profile. And they primarily chose chlorpromazine to help with blinding, because it's really hard to blind clozapine studies because the side effects are so specific. So they found that the average, that 80% of patients were treated to remission, so high remission rates as you might expect in a first episode study, but it took on average 8 weeks for clozapine-treated patients to get to remission versus 12 weeks for chlorpromazine-treated patients. That was a significant difference. The clozapine-treated patients also had a lower relapse rate, so that by the end of the year, the clozapine-treated patients had spent twice as much time in remission as the chlorpromazine-treated patients. So again, you don't see an immediate symptom response difference, but you see a change in ability to maintain that over time, and no difference in weight gain, with chlorpromazine having a fairly substantial weight gain profile as well. So that leads to the project that we've been doing. This was initially a R31 grant funded to Alan Green and these are some of my other collaborators. We've been doing a series of studies looking at antipsychotics in substance use disorders, and Dr. Green had also been doing some of the work, as you see here, looking at first episode patients. So this is kind of pulling it together and thinking about if you did want to place clozapine in a first episode population, where would you want to place it? Now, a group up at Toronto has done some work thinking about sort of where you would place it in a sequence, and they talk about putting it sort of third in line in a series of trials with a first episode patient, but with a sort of an 8-week turnover cycle for trials. In this case, we were thinking that if you wanted to put clozapine first, folks with a co-occurring cannabis use disorder may be the most appropriate patients to do that with, because there's substantial potential for cannabis toxicity during that early critical period. I'll review that data on the next slide. Clozapine appears to inhibit substance use, and again, we've been doing randomized trials to establish that and augment the naturalistic literature. Clozapine may extend time in remission, again, which may improve long-term outcomes. but there's substantial risks to it. So you probably don't want to expose everybody in first episode to clozapine. In fact, the majority of those people might not require it. So if cannabis use disorder is a marker for people with poorer outcome, these may be a group of folks with a greater risk-to-benefit profile. And so, again, as I mentioned, there's a fair amount of risk for cannabis toxicity. We see a higher rate of onset of schizophrenia in regular cannabis users, and the group Caspi and colleagues looking at a birth cohort in New Zealand established an interaction with one of the risk genes for schizophrenia, so that adolescent cannabis smokers who also had the risk gene had an elevated rate of developing schizophrenia, whereas those who didn't have the high-risk CMT allele did not show the elevation in rate. About half of first episode patients are already abusing cannabis. They demonstrate an earlier age of onset of their psychotic illness and a poorer course of illness, but also demonstrate greater neurodegenerative changes. That Monica Reyes, in a study published in the American Journal in 2008, demonstrated with serial MRIs that a group of individuals who continued cannabis use after first episode of schizophrenia demonstrated more brain volume loss compared to a group who were able to stop using cannabis. So our study design is to look at a 6-month single-blind randomized trial. We use the single-blind methodology because, again, it really would be impossible to blind risperidone and clozapine because the side effects are so different between the two. We're looking for a pilot sample of individuals between 17 and 45 years old who met criteria for schizophrenia or schizoaffective disorder and a cannabis use disorder simultaneously. Randomly assign them to clozapine or risperidone with weekly assessments on the timeline, follow back for substance use outcomes, monthly urine screens and breathalyzers, as well as collateral ratings from a family informant, and then a series of symptom measures as well as metabolic measures over time. And we developed a lifestyle intervention to help with overcoming some of the metabolic side effects. I'll just show you a couple of our case examples from this study, and then show you a summary of the findings to date. One of the findings, like the Werner trial, is that first episode patients may have a very hard time tolerating clozapine. So this is actually an example of one of our good outcomes on clozapine. A young man who was 18, senior in high school when he entered the study, had been psychotic just for a few weeks, had been treated with risperidone for 1 week in our inpatient unit before he got randomized to clozapine, got titrated up to 75 milligrams a day and had complete remission of symptoms, so a remarkable response at a very low dose relative to chronically ill folks. Gained a lot of weight early on, worked with us in the lifestyle intervention to help to turn that around. He actually last summer ran a triathlon and has not only had a remission from his substance use disorder, chose at the end of the study to stay on clozapine. I actually still follow him clinically. He's now out to about 3 years on clozapine, and moved on from working full-time to going to full-time college and working part-time, and as well as starting a badminton club at his college. So, just a remarkable example of a young man who was, clearly met full criteria for schizophrenia and cannabis use disorder, and has demonstrated a really nice sustained remission with clozapine. In contrast, another 18-year-old high school senior came into the study, had just had a couple weeks of symptoms and had been started on quetiapine clinically before he got randomized to clozapine. Couldn't tolerate it, felt drugged, headaches, couldn't get himself out of bed. We tried going up and down on the dose, and we couldn't get to a place where he could take it. He finished the rest of the trial on an intent-to-treat basis, taking open-label quetiapine, and later was treated with risperidone, long-acting. Had fairly poor outcomes, lived with his family for a period of time, but had multiple relapses, kept using drugs, had a severe episode of self-mutilation, a lot of disorganization and distress, and ended up in a residential facility where he got kicked out after a while for substance use. So, a classic sort of first episode bad outcome in somebody who couldn't tolerate clozapine, and of course you wonder what might have happened if we could have kept him on it. Case example of a gentleman who was a good responder to risperidone, joined the study at the age of 19, had a diagnosis of bipolar prior, came in a manic psychotic episode, met criteria for schizoaffective disorder, had been on valproate. He got treated clinically with risperidone prior to randomization to risperidone, was able to bring the dose down as he stabilized. It had some side effects and improved as the dose came down. Through the course of the study, he continued to intermittently use cannabis and alcohol with some evidence of reduction of use. As soon as the study stopped, he said, thank you very much, but I really don't want to take this risperidone stuff anymore. I'll just take my Depakote. Relapsed, has now had several antipsychotic trials. Has able to keep up his success as a competitive snowboarder. Actually came back to see me before heading out west this winter and was completely psychotic, and his family was very worried about him. Was off meds again. He also was able to do some ongoing college part-time. So, reasonable response to risperidone, some improvement in substance abuse, but wasn't able to sustain it over time. And didn't end the study saying, this is great stuff, I want to stay with it, the way we saw in the first example. And here's an example of another patient who I actually also follow still, who had a difficulty tolerating risperidone. Was on between 1 and 4 milligrams a day, had a lot of weight gain, a lot of fatigue, was not adherent with the medication, was concerned about his weight gain, dropped out of the study after 13 weeks and had a series of relapses and hospitalizations, various medication trials. He actually is taking quetiapine at this point, and he's continued to use cannabis and still is now, 3 years later, using cannabis on an ongoing basis. So we ended up with mean ages of around 23, although the examples I just showed you were a little bit younger. Reasonable distribution of gender. Our demographics, as I was telling Dr. Moreno earlier, are primarily Caucasian in New Hampshire and Vermont. Interestingly, that while we had a allowed dose range up to 250 milligrams of clozapine, turns out that we never used more than 100 milligrams. Our range was one young woman who responded to remission on 12.5 milligrams a day of clozapine. The highest dose was 100 in the trial with an average of 75 milligrams a day. So that's really an order of magnitude lower than other studies have shown, and an order of magnitude lower than we would use in treatment of chronically ill folks. But even the earlier studies I showed you with clozapine were generally using several hundred milligrams a day for most patients. And we used this really slow titration process after some of our early misadventures with clozapine, which did improve our tolerability profile and also resulted in very nice responses at low doses. Risperidone ranged doses between 0.5 and 5 milligrams a day, so again, somewhat on the lower side, a mean of 3.1 than you might see with chronically ill folks. We saw no discontinuations for lack of efficacy, more discontinuations in the clozapine group for lack of tolerability, and a few for just patients' decision not to continue. At the point of getting 14 people randomized, our study coordinator left us and our funding ran out, and we need to get the study restarted now. But at the preliminary analysis, we found that it seems like fewer people are staying on clozapine through the course of, or tolerating the early treatment with clozapine than risperidone. But those folks who do tolerate clozapine out to 6 months then tend to vote with their feet and want to stay on it over time. With each of the successful clozapine completers choosing to stay on it at the end of the study, and some of whom have stayed on it long term. You saw the trends in the substance use outcomes, and the analyses we're going to wait to do until we have the full sample recruited. So that's a picture of the Adirondacks in New York, where I spend some time in the summers, and reminding me to sort of shift gears to the second half of the presentation. So we've been doing a lot of work looking at supported employment as an intervention for people with schizophrenia. And this is a summary of a series of studies, a couple of which we implemented the Drake studies in New Hampshire. Gary Bond, who works with us now in Indiana. Bill McFarland, who's now up in Maine, showing that supported employment interventions, essentially having a job counselor that integrates with a case management team and goes out and does the legwork with clients on helping to find competitive employment, can dramatically elevate rates of employment and achieve 50 to 75% employment rates amongst people with schizophrenia relative to controls. And along the course of doing this work, we learned that having lots of clients want to work, very few of them are. It becomes a very motivating process for them, and often helps to then become a motivator for their adherence to treatment, because they may not be motivated to take antipsychotic medication to get rid of voices that they enjoy listening to, but they may be motivated to do it if it helps them to be successful in keeping their job or their relationships that they have in that setting. A number of patients who were medication adherent but had residual symptoms found that they were able to focus their attention on their job tasks and pay less attention to their symptoms, and demonstrated some, if you will, augmenting effects of the vocational intervention of the work activity on helping them to manage their psychotic symptoms better. Bob Rosenheck at Yale has demonstrated that clozapine relative to haloperidol was associated with a doubling in the rate of participation in psychosocial treatment in the VA system. One of the first studies to suggest that second-generation agents, with their impact on cognition and on negative symptoms, might be able to change the way that people respond to psychosocial interventions. This study at the Thresholds group in Chicago that we collaborate with looked at naturalistic second-generation treatment, olanzapine and risperidone, versus first-generation agents, and showed some trends in the direction of improvement in cognition and hostility that were associated with independent employment, but didn't have a large enough sample to show a direct relationship between medication assignment and successful work. In a project that I did, I'm running out of time, so I'm just going to cut to the chase here. We looked at folks that were initiated with olanzapine in the Community Mental Health Center that I worked with in Manchester, New Hampshire, versus the group that were staying on first-generation antipsychotics. And this is change in competitive employment over a 3-month period of time, with folks who switched to olanzapine from first-generation agents showing a tripling of the increase in work hours in response to a rehab program compared to the folks in the pink bar over there who remained on first-generation antipsychotics. The middle group in the white bar are folks that were initially on first-generation agents and eventually converted to second-generation agents, and they showed an interval increase in their employment rates as well. Again, suggesting that the second-generation agent may have been associated with some enhancement of response to psychosocial rehabilitation. Our collaborators at UCLA, Shirley Glynn and Steve Martyr, Bob Lieberman, did a similar trial. In this case, they were looking at haloperidol versus risperidone and social skills training, but weren't able to find an association between the second-generation agent and better acquisition of social skills. Steve then went on to get funding for this MARS-3 study, which was the sequel to the last one, and Bob Drake and our group at Dartmouth also collaborated in this study that was sort of a 2-by-2 study design, randomizing people to either olanzapine or risperidone, which at the time this study was funded in the late 1990s were the 2 primary second-generation agents that were available, and also randomizing them to 2 work interventions, a standard supported employment versus one that was augmented with workplace skills training. And so we looked at those groups over time, and we've just the work outcomes are still being looked at, and Shirley Glynn is taking the lead on that. This is the skills intervention. We looked at folks from 18 to 60 with schizophrenia or schizoaffective disorder who were medication adherent, stable, not in an acute exacerbation, unemployed, and interested in work, and without developmental disabilities or substance dependence. We recruited 107 people. We found that continuation rates were similar between olanzapine and risperidone over the 12 and 18 months. And in fact, if you look at our 18-month continuation rates, they're almost identical to the CATIE outcomes, with about a third of patients staying on their assigned antipsychotic at 18 months. Median time on medication looked somewhat longer with olanzapine, but there actually were no significant differences there. And again, our 18-month all-cause discontinuation rates are very similar to the CATIE trial. That's what it looks like graphically. Sorry if I'm blinding you with the bright light, but the Med-O is the olanzapine, Med-R is the risperidone group, and you can see that So this is survival on medication, which was not significantly different between the two groups, but a bit of a trend towards the olanzapine survival being a little bit better, as you see in a lot of other studies. We found that both groups actually had significant improvements in psychosis and suspiciousness, as well as one of the avolition component of the schedule for assessment of negative symptoms. So both positive and negative symptoms improving over time in folks who were already stable at baseline and who were getting randomized amongst medications, some of which they were already taking. The only difference between the two medications was that risperidone-treated patients had some greater improvement on somatization than olanzapine-treated patients. Haven't quite figured that one out, unless it's a correlate of weight gain. Weight gain was an interesting finding, though. As you would expect, folks that randomized to risperidone actually showed a 1.1 BMI point drop per year, whereas folks randomized to olanzapine had about a two-thirds of a BMI point increase per year. That was a significant difference between the two medications, but surprisingly lower than in the CATIE trial, where there was about a twice as much weight gain in the olanzapine-treated group, about a 1.5 BMI points. And again, our folks are entering work, which was not a component of the CATIE trial. No differences between the medications on glucose or lipids, even though you might have expected that in a trial that wasn't involving work. And interestingly, HDL cholesterol, a marker of physical activity, is rising in both groups, suggesting that there's an increase in physical activity associated with the work outcomes. No differences in tardive dyskinesia outcomes. In the CATIE trial, there was a reanalysis that showed that if you got randomized to your prior medication, you did better. So we looked at that in this study as well. It turned out that about a quarter of patients were taking risperidone at study entry, and about a third were taking olanzapine at study entry, with another 37% taking a different medication, pretty much first-generation antipsychotics in the neither group. As you see on the next slide, and again, sorry for the bright light. So N is neither, R is risperidone, O is olanzapine. There were no significant differences amongst the groups, but we didn't see a trend for being assigned in the randomization to the same med you had before as being an advantage. You can see the OO and the RR groups are sort of in the middle there. Folks that got randomized, actually both groups that got randomized from a first-generation agent to olanzapine or risperidone did the best. And folks who got randomized from risperidone to olanzapine also did quite well, whereas the reverse, the folks who got randomized from olanzapine to risperidone had the worst outcomes, and in fact, they had a higher rate of hospitalization for relapse, and none of them were able to survive for the 600 days point without having a relapse. So some evidence of poor outcome in that group. Just quickly, one case example illustrating the point that this is a gentleman with very severe psychotic illness. He had commands from God to amputate his fingers and toes as a sign of loyalty. Had been managed on both a long-acting decanoate and clozapine for many years, many state hospital admissions. Was starting to get into his 50s, and although even within a year prior to starting the study, it had amputated a toe and had gone back to the state hospital. But he always resisted having an identity as a patient, saw himself as a plumber. He actually had a successful career in his young days before getting ill. Had been unemployed for decades by the time he entered the study, but demonstrated a good response. He was randomized, got onto our highest level. We had levels 1 to 10 that corresponded to 1 to 10 milligrams of risperidone or 2.5 to 30 of olanzapine. Had improvements in his psychotic symptoms despite switching off of clozapine and fluphenazine onto study medication. Started to participate in more shared decisions. Got a part-time job as a custodian that he was thrilled with, and started to take so much pride in himself that he recontacted. He actually had children that he hadn't been in contact with for decades that he got engaged with, and began to be much more motivated for following through with his treatment. Now, not everybody had as positive a response as that, but we do see many patients demonstrating greater self-esteem and pride, as well as I mentioned before, that sort of reason to be well that tends to improve adherence to treatment over time. and also an external anchor for their attention that may draw the conscious thought away from psychotic symptoms. And I'll just skip through that quickly. Our conclusions were that olanzapine and risperidone had similar overall effectiveness, with an advantage for risperidone in change in BMI, but a surprisingly low change in BMI in both groups that may have been potentially moderated by recruiting people at a stable phase of illness rather than an acute phase of illness, as you see in many other trials, as well as our close monitoring of metabolic outcomes and employment rates, employment leading to greater physical activity, which may have helped with weight management. The switch from olanzapine to risperidone was associated with higher relapse rates, but the overall improvements in both positive and negative symptoms, as well as the interesting rise in HDL cholesterol, may have been mediated by the employment activity, again suggesting that employment might not just be a functional outcome of interest, but may also be an augmenter of antipsychotics and help them improve not only psychiatric symptoms but also physical risks. Okay, so as we think about enhancing response to antipsychotic treatment, we want to think sort of at both ends of the disease. Obviously, when we have the opportunity, we want to intervene early, try to prevent the fixation of the disorder by early identification and treatment, providing neuroprotective interventions, reducing time in psychosis, reducing substance use, and helping people to achieve sustained remissions. I'm quite impressed to say that in the clinical work as well as the research work that we've done in this area, I've now been able to treat enough people who've been able to engage in committing to sustained treatment that have achieved very good outcomes over time, that I'm convinced that early interventions can make a substantial difference in outcomes in this disorder, and it's really getting clients and families on board with that helps to engage them in taking on treatment with what can be difficult to tolerate medications. In addition, integrating with rehabilitation and psychosocial recovery interventions can improve functional outcomes over time, as well as improving response to overall treatment response and tolerability. And of course, the goal of all of this, when we think about it, is to move the meaning of having a diagnosis of schizophrenia from this devastating, lifelong disabling illness, sort of the way that the very negative, ominous perceptions of cancer really were present in my medical school days, to the place that we've gotten with cancer, where, cancer is still a devastating diagnosis. It's a very significant set of disorders, but we have a lot more hope. We have a much different public image, and we've certainly gotten people to the point of recognizing that if you have any indications of having a problem, you want to get identified and get treated as soon as you can to improve your long-term outcomes. And if I think that as our field works to get to the place with schizophrenia that we've gotten to with major depression and a number of other disorders, that now politicians can say I've had depression and I've been treated, I'm okay, and people are comfortable with that, or celebrities will talk about it and such, and bipolar disorder to some degree as well. I think we also need to be able to get to that place where we can view schizophrenia as a treatable condition that can have positive outcomes when treated successfully. Questions? We have just a couple of minutes. I don't know, can we go over 5 o'clock?